So I'm going to give you a bit of an update. So I'm a chemical pathologist at University Hospital Sussex, currently working out West, so St Richards and Worthing. The next slide, please, Jason. Thank you. So we're going to give you a bit of an introduction, some information about Inclisiran, but we're going to look at some cases just to give you some more examples of how to use it in practice. Next slide, please. Thanks. So effectively, the theory and all the evidence is unanimous. The lower the LDL, the better. You cannot get atherosclerosis in the absence of cholesterol. And we've shown that LDLs down to 0 result in people getting better outcomes faster. So there is no lower limit. Before, of course, we could never get anyone to 0, but now we're getting into the era where we have got enough drugs to get people, everybody, hopefully, to target as much as we can. And so our focus has gone from just starting some statin and then leaving to actually aggressively managing all these additional drugs so that we can get people the maximum LDL reduction that we're able to give them faster regression and more likely to be in the group of people who have regression of atherosclerosis rather than continuation. Next slide, please. This is just a slide showing, so the bottom line is the drug trials showing you this linear effect of LDL reduction. So the lower the risk, the lower the cholesterol. The top line is just showing you the difference it makes from birth. So the longer you have a low LDL for, the more effective it is. And it basically, again, comes back to the fact you cannot get atherosclerosis if you don't have cholesterol. So if you get it down low and you get it down early, you're more likely to never get atherosclerosis or be the person who has regression of atherosclerosis. Next slide, please. One of the major things that's really changed was discovery of PCSK9. So there were families discovered who had no LDL cholesterol, so 0, who had no clinical consequences, so completely normal, except complete absence of atherosclerosis, so no heart attacks or strokes. From discovery of these families' mutations, which is an absence of a protein PCSK9, they used antibodies to remove it as a test. And it's the fastest ever from discovery of a genetic mutation to a drug being available in the market, because it took less than 10 years. So obliteration of PCSK9 to mimic this genetic disease really reduces LDL cholesterol beautifully and has no consequences except to reduce atherosclerosis. PCSK9's role in vivo or physiologically is to bind the LDL receptor. So instead of the LDL receptor binding LDL cholesterol particles, it binds PCSK9. This receptors then go inside of a cell in a process called clathrin-coated receptor-mediated endocytosis. If the LDL receptor is bound to LDL, the LDL can be degraded inside the cell and the cholesterol used. If it's bound to PCSK9, the LDL receptor goes to the lysosome and is destroyed. So it's part of a natural sort of life cycle or turnover of an LDL receptor. And if you think an LDL receptor removes 20 LDL particles per minute, destroying LDL receptors really reduces your ability to take up LDL, because eventually they'll become dysfunctional and then get removed themselves. But PCSK9 basically indiscriminately removes some of your LDL receptors constitutively. If you mop up the PCSK9, the only thing that happens is you remove your cholesterol from your blood vessels, so you can use it intracellularly. Alirocumab and evolocumab, which were first drugs in this class, are basically just antibodies produced, fully humanized, but mop up the PCSK9 in the circulation. Next slide, please. Inclisiran, which is in the top left there, is working on PCSK9 too, but it's an oligonucleotide antisense probe, so it's an mRNA-based drug. Basically, it stops you making any PCSK9 in the first place. So Inclisiran stops you making the protein, and PCSK9 inhibitors remove it from the circulation, but both are working in exactly the same way, which is to reduce your concentration of circulating PCSK9, and are both extremely effective, meaning you have a reduction in your LDL with no other consequences. So this now joins our really quite large armamentarium of lipid-lowering medications. So we have statins, which inhibit cholesterol synthesis in all tissues. So I've drawn here the liver and the muscles, for example, and the muscle effect is why we theoretically think there are muscle side effects, though they are extremely less common than everyone says they are. Bempedoic acid, which is another new agent, also inhibits cholesterol synthesis, but it only does it in the liver. So that's why bempedoic acid has a use for people who are on low-dose statins because of muscle intolerance, because it can have no muscle side effects because it doesn't work in the muscles. Then you've got your ezetimibe, which blocks bile acid transporter in the gut, so you lose some bile acids, and bile acids are made from cholesterol, so that uses up some of your cholesterol stores. And then you've also got icosapent ethyl, which is now green on the formula and is a fish oil, and we don't really know how that works, but that reduces cardiovascular risk as well. It reduces triglycerides, but we're not sure. Well, we know that that's not all of why it's the benefits there. We think it's perhaps anti-inflammatory. So we've now got a whole plethora of drugs to choose that reduce cardiovascular risk. Next slide, please. So Inclisiran got a nice tag, and it's recommended as an adjunct. And basically the criteria are extremely similar, but not identical to the ones for PCSK9 inhibitors. And it's basically secondary prevention. So ACS, you need to come into hospital, and that can just be for unstable angina, or revascularization. So pre someone's heart attack, for example. A diagnosis of coronary heart disease, so that's all quite vague. Ischemic stroke, so TIAs aren't on that list, and peripheral arterial disease, so any of those. And you need an LDL consistently above or equal to 2.6. It says on maximally tolerated lipid-lowering therapy, so it does not stipulate that someone has to be on any specific therapy, but we would have expected everyone to have tried statins and ezetimibe, etc., first, as they are standard therapies. But it doesn't matter if a patient then doesn't take them. You expect to have given those a go first. And then, of course, there's the commercial arrangement. Next slide, please. So this is the criteria, basically identical to PCSK9 inhibitors, but they have much higher thresholds. So you can't use those unless your LDL is greater than 4 for one vascular event, or 3.5 if you have more than one vascular event or more than one vascular bed affected, such as a stroke or heart attack. And PCSK9 inhibitors you can use for primary prevention, but only familial hypercholesterolemia, and only if the LDL is greater than 5. So that's very few people there for primary prevention, but it's the only injectable that we can use for primary prevention. If you've got FH, you have a slightly lower threshold for secondary prevention, so only one event needs an LDL of greater than 3.5. But as you can see, these values are very high, because if we want our LDL 0, before, if your LDL was 3, for example, so considerably above the standard cutoff of 1.8, and again, remarkably higher than 0, there wasn't anything else we could do. So bringing Inclisiran down to 2.6 allows us to treat some more people who before we were unable to treat. Again, there's still, you can see a group of people who we still can't treat, but it's helping us treat more people. Next slide, please. We've tried to simplify this in a pathway which is probably already a bit out of date, but basically this is just taking you through it. Exactly the same is in the national pathway, except there's so much on that we thought we'd just draw one flowchart to make it really clear. So if you have secondary prevention patient, you'd start with your max dose statin, which is a Torva 80 or Rasuva 40. Just some, where is that better? Yeah, and then if you haven't had your reduction, so technically the previous NICE guideline said 40% reduction, but that's all you get from 20 milligrams of Atorva. So it's basically a bit out of date, because at the time of writing we didn't really have anything else to do, so there's no point asking people to do more. But basically our secondary prevention target is at least less than 1.8. So you're looking for a percentage reduction and as low a LDL as you can. So if they aren't at target, then consider adding ezetimibe. And in many ways, there's a debate about why we wouldn't just start everyone on ezetimibe anyway. Now it's off patent, it's nice and cheap, extremely safe and effective. But currently, the guidance would have it in a more stepwise fashion. Then if you're still not at target, if the LDL is above 3.5 or 4, that's when you'd send them up to clinic for a PCSK9 inhibitor. The way it's been commissioned, etc., means it is only available out of secondary care, because it'd be considerably more expensive to use it out of primary care. So then you'd refer them up to lipid clinic. If the LDL is less than 3.5 or 4, but greater than 2.6, that's when you do Inclisiran. And then we've got bempedoic acid here, but bempedoic acid could be added to any of these. If they're also on low dose statins and ezetimibe and they're still not at target, you can add in bempedoic acid, either to just low dose statin or nothing and ezetimibe, or to low dose statin, ezetimibe and inclisiran, or low dose statin, ezetimibe and PCSK9 inhibitors. So it can add added on to any of these drugs, but if they're still not at target, think about bempedoic acid in your statin intolerant people. We've also now got icosapent ethyl, which you can also add in to people with hypertriglyceridemia and LDL, but we're focusing on inclisiran here. Next slide, please. So this is a summary of all the LDL lowering drugs. So you've got a high intensity statin, so between them, so 20 milligrams of atorva is roughly 40%, 80 milligrams 50% for LDL reduction. Ezetimibe is 24%. So these drugs have been around a long time. They're extremely cheap, very safe, and we've got lots of data, so safety data and CVD reduction data. Then we have our PCSK9 inhibitors, who will give about 60% reduction. Again, extremely safe, very well tolerated, but the patient has to inject themselves every 2 weeks, which can add a little additional complexity there. But most people have managed without any problems at all. And they now have CV outcome data, but interestingly, they also had a nice tag before the outcome data was available. And there's nice safety data. Bempedoic acid is still awaiting outcome trials and safety data. And has a reduction about 28%. And then we've got Inclisiran, which is about 50%. And again, also waiting data. Of course, we know that cholesterol synthesis inhibition and PCSK9 reduction do have CVD reduction. So we're not concerned that there won't be CVD reduction in risk. So it's just for long-term safety data waiting, but so far they've proven to be nice and safe. Inclisiran, actually, we've not found any problems with at all, which is interesting and exciting. But this is why we do statin, ezetimibe, PCSK9 inhibitors first, and then the other two later. Thank you. Yeah, next slide. So we think the nice guidelines are very much out of date and hopefully will be updated at some point. But I think we're getting away from this step where we do every single drug, have a wait, have another think. But instead, what we suspect new guidelines will look like will be combination therapy right at the beginning. So when you pitch up your vascular event, everyone has at least a statin and ezetimibe without any consideration of what their LDL is. And some people even get a PCSK9 therapy right at the beginning. And this will be based more upon risk as well as cholesterol, which would be more in keeping with European guidance. And then you would then assess them to see how low you've got, and we're going for a low LDL, so at least less than 1.4. And that's when you might add in further therapies. So currently we think there's lots of steps, which makes it slightly more complicated, gives you the increased risk of losing patients, and we're not going for the low targets that we know are evidence-based to reduce cardiovascular disease. Next slide, please. So a few little facts. The drug only lasts for 14 days, so patients are very worried because if they've had side effects to other things, but if it's a 6-monthly injection, they'll have side effects for 6 months, and that's wrong. The drug's only around for 14 days. It's just the effects of the drugs on LDL last much longer. The lowest point of the LDL, so if you want to check how the most effective it's been, is 8 weeks after the second dose, so that's 5 months after starting. There are no known side effects, except of course you can have, because you're injecting it, a little red around the injection. No known drug interactions, but of course, yeah, no one's done any tests in pregnancy, breastfeeding, or liver failure. Next slide, please. Right, so our first case, we've got a 62-year-old man here. So he's had an ischemic stroke proven, so he's on good prevention with atorvastatin 18 and ezetimibe 10. So here's his results. He's got cholesterol 4.2, trigs 1.2, HDL 1, and an LDL of 2.65. So now we're thinking about what next. So until a couple of months ago, nothing. There's nothing more we could have done for him. He can't have bempedoic acid because it's a hard dose statin, because bempedoic acid was the first for drugs to get its nice tag. However, now we know that his LDL is above 2.6, so we can add in Inclisiran. And that's what you want to do, because if you're thinking to yourself, what is my target? You can go for a target of less than 1.8. You can go for a target less than 1.4. Personally, I have the LDL target of 0 in my head. Ideally, I'd like to obliterate their cholesterol. It's just we're not really allowed to because of the way the drugs are licensed. But that's basically in your head. You're like, if my patient has a detectable LDL, is there anything else I can do for them? And so this chap, the answer is yes, and that's Inclisiran here. Next slide, please. So next case, we have a 55-year-old woman. So she's got a genetic cholesterol condition, familial hypercholesterolemia with plaque found on angiogram. She's on Simva 40, ezetimibe 10 milligrams, and this is probably because she's been diagnosed for quite a long time. People can get quite attached to their lipid-lowering medications, and so it can be difficult to transfer them over. So ideally, you'd want her on a higher potency, safer statin, such as Torval but here she is. So her cholesterol was 6.42, trigs 1.08, HDL 1.3, and LDL 5.12. And here are her results after starting Inclisiran, which is extremely effective, as you see here, once every 6 months. So this woman has had high cholesterol from birth. So you really are aiming to get her LDL down as much as possible, because you don't have 10, 20 years of high cholesterol to combat here. You've got 50 years of cholesterol to combat. And almost all her risk you'll probably find is related to the high cholesterol from birth. The difficulty, though, with familial hypercholesterolemia is how high the cholesterols are to start with. So even with her simvastatin and ezetimibe, she had hypercholesterolemia. So tricky to get them down to 0. But these are a patient group who may have little atherosclerosis at young ages, but you want to be extremely aggressive with to make sure they remain free from atherosclerosis, or that the rate of progression is slow. She would actually be eligible for PCSK9 inhibitors, so I think we did start them, but she didn't like them. Of course, there's a bit of patient choice here. Some people are needle phobic, but again, we have found that the needle phobic patients have managed with PCSK9 inhibitors, but there is that choice. But technically, the PCSK9 inhibitors would be more effective than Inclisiran. And they say they give a 60% reduction, but she's had a 60% reduction here with Inclisiran, so that's a really good result. Next slide, please. We have a 74-year-old woman, so she's had intervention with PCI and stents. Other risk factors, so she's got rheumatoid arthritis, which of course a cardiovascular risk factor due to that inflammation, CKD. As we know, we get a lot of atherosclerotic disease in CKD. UC, so again, underlying inflammation potentially. On atorvastatin 40 and ezetimibe 10, so quite good therapy there. If you doubled the atorva 40 to 80, you'd only have an extra 5% reduction in LDL. So it's definitely worth considering, but sometimes in your older, frailer people with multi-comorbidities and multiple medications, it may be not worth the risk of increasing the dose to get a 5% reduction when you can add in something that will be more effective. So here, you've got a cholesterol of 6.4 and an LDL of 2.85. So she does meet the threshold for Inclisiran. And of course, Inclisiran has no side effects and no drug interactions. So we started that. And as you see here, she's had a 40% reduction. So ideally, we're going for an LDL of less than 1.8. She's still not at target, but it's considerably normal. I think someone needs to be on mute. No one check, please. Thank you. Yes, her HDL also, it was a little bit high. This is just a technical point here. So actually, I think her LDL probably fell more than that. This is an underestimate, because you work out LDL by minusing HDL from total cholesterol, and it's settled again here because that's really high. So I think that's probably an aberrant measurement. And therefore, when you've taken it away, if you've taken 2.4 away here, it would be much higher LDL. So I suspect she's had a better reduction than you're seeing. It's just the calculation's gone a bit squiffy because she seems to have a bizarrely high HDL here. But that's just a technical point. Next slide, please. So 71-year-old woman, so cabbage and stroke, so 2 vascular events, 2 different beds. polygenic hypercholesterolemia. So we obviously suspected she might have FH and genotyped her, but she was negative. But she's got multiple small changes in the DNA, which can give you cholesterols almost as high as familial hypercholesterolemia. The difference with polygenic is that it tends to get worse in adulthood. So we tend not to have such a high cholesterol in childhood, which means the risk is slightly lower because the time exposed to the high cholesterol is slightly lower. But that's, of course, we know there's multiple other cardiac risk factors, so it's just one of them. But generally, it has a lower risk than familial hypercholesterolemia. She's also got a positive lipoprotein(a), and she's on rosuvastatin and ezetimibe. So here are her lipid results. She's got cholesterol 4.62 and an LDL of 2.8. So because she's got vascular disease, secondary prevention, her LDL's too low for a PCSK9 inhibitor. We started her on Inclisiran, and you can see here a nice good response. So a 40% reduction. Lipoprotein(a) makes LDL slightly resistant to lowering. So if you don't see an LDL reduction that you expect, one of the questions you could ask yourself is, have you missed a secondary cause for hypercholesterolemia, such as diabetes, liver disease, alcohol, hypothyroidism, or something like lipoprotein(a), a genetic condition that makes it resistant to come down? So that's still a good response for her, and we now have got her beneath our 1.8 target. Next slide, please. So now we've got a 58-year-old man, 2 strokes, but his first, he was only 42 years old. So this is a person, again, you want to be really aggressive with, because that's way too young. He's lipoprotein(a) positive, but FH negative. So you would be expecting a genetic condition here. But, you know, he's also obese with a BMI of 43. He stopped smoking when he had his first stroke. And here's his results. So his cholesterol's 4.8 and his LDL's 2.44. So that is too high. We want it less than 1.8 at least, but as you note, it is less than our 2.6, so we cannot give him Inclisiran or the other PCSK9 inhibitors where the targets are even higher. However, the only light might be here that his triglycerides are raised at 3.82 and his HDL is low at 0.9. That's called the atherogenic lipoprotein phenotype, and again, it means he's fat, which we knew from his BMI, but if his BMI was 28, 25, you'd still say he was too fat from these bloods. As he loses weight, his triglycerides will drop, and what we'll see is that the LDL climbs up. So the instructions of this chap was continue taking his atorvastatin and ezetimibe and lose some weight, because if he can lose some weight, his LDL will creep up above the 2.6 target, and he should become eligible for additional lipid-lowering therapy. He will also, of course, gain the massive benefits and the weight loss and the reversal of the atherogenic lipoprotein phenotype. So don't despair if you find someone just at a cutoff with hypertriglyceridemia. Make them get those triglycerides down, because it has twofold benefits: general health benefits, and it will mean the LDL comes up higher so you can treat them. Next slide, please. Yeah, so that's what we were planning. So Inclisiran facts. You don't need to monitor it technically, because there's nothing required, because it's nice and safe and it reduces cholesterol. But of course, all these patients will be under their annual CVD review anyway. They may be keen to know what the benefit is, so I'm sure they will all get repeat cholesterol measurements, but there's no liver or kidney monitoring, etc. required. If they miss a dose, but they're within 3 months, then just administer it and then carry on with your original schedule. If it's more than 6 months, you have to start again, which means that 3-month loading dose and then back to 6 monthly. The drug costs 45, but you're reimbursed at 55. I think so not all areas which we'll go through, but locally, you can also fill in your LCS for minor procedures injectable form as a multi-claim form, and you get additional money. So it's not, you get more than £10, but this varies a bit, and that's all being sorted out and harmonised, I think. Next slide, please. Oh, there we're at the end. Rich, do you want to go next, and then we'll do questions at the end? Thank you.
Thank you, everybody. I'm sorry there was a bit of confusion about that. I noticed there were 2 different links to signing on. I mean, I saw them as well, but one of them was hold the date and the other one. So apologies if there's anybody who hadn't been able to join, then obviously we can send an invite for the next one. So I'm Richard Blakey. I'm a GP by trade, but my main job has been related to cardiology over the last 20 years. just to give a bit of background, just to explain, because I think one of the problems with Inclisiran has been very much sort of a hearts and minds and a bit of concerns about the drug, to try and explain why it hasn't taken off in the way that was expected. So why am I happy that it's been given and to prescribe it when I'm locuming as a GP? Is that so I've been dealing with lipids going back to 1989, and when I was a GP trainee in Cornwall, my GP trainer was a hospital associate at Trelisk Hospital in Cornwall. So I was dealing with patients in his practice for primary and secondary prevention way before I think it was happening in any great amount elsewhere in the country. I have been working with CVD from the 1990s, in the days of PCGs, before PCTs. I was the local cardiovascular lead for part of Sussex, and then been involved ever since then, 20 years in Eastbourne Hospital, doing primary and secondary prevention in cardiology. I've been GPSI in cardiology since 2009. So I've dealt with a lot of drugs in cardiology and in lipids that have come in with varying amounts of concern about their use, about their initiation, potential side effects, outcome evidence, etc. And I feel that I've now got enough information. I'm happy to both prescribe it myself, but also recommend that others use the drug. I'm just really going to sort of talk about things, the experience of work that I've done with GPs locally, in the hope that it can maybe provide a bit of reassurance, but also during the question and answers, hopefully any other sort of queries about it can be addressed by myself and Kate. If we go on to the next slide, please, Jason. So when Inclisiran got its approval from NICE, part of the deal was that the drug was going to be supplied to the NHS at a dramatically reduced cost. I mean, if you look, and I think sometimes when people go to use the drug, it still comes up on your system that it's almost £2,000 a dose. But that isn't what you're going to pay, and whatever happens in the future, I don't think anybody should ever be worried they're going to suddenly start being landed with a bill of £2,000 a dose for these people. It isn't going to happen, and you're not going to be burdened with that on your sort of local formula, etc. But I think that's possibly one of the reasons that it's not been sort of taken up as quickly. There's a lot of misunderstanding about it. The pathway believed that it's a secondary care drug, but it was very much designed to be a primary care drug, and that was partly to help people like Kate, who would be absolutely overwhelmed, as there are so many people with established cardiovascular disease who aren't optimized at the moment, and there's just no way a lipid clinic could cope with it. They're already overwhelmed because of the requirements now for GPs to referring people with suspected FH, that if you added in all these people with raised cholesterols with a LDL of 2.6 or higher with previous cardiovascular disease, they just wouldn't cope. We'd have no lipid service at all, and as a result we'd end up then with far more cardiovascular events. So this is a primary care drug. That's the way that it's been set up. The expectation was there would be 300,000 people started on the drug over 3 years, so 100,000 per year. So our share of that would certainly be in the thousands. And if you see that this was, the process started in November 21, we've nearly got a year, and yet the monthly numbers for our 3 different ICB areas is way below what would be expected. What is interesting in this is that there is a little bit of a difference. So Kent, Medway and Surrey have flatlined. So these are the monthly orders. You would expect that within the monthly orders are not just the new people being initiated on it, but the people who are now established on it, who are having their 3-month first follow-up, and then 9 months, and then every 6 months after that. So the numbers shouldn't be flat. They should be increasing from the people who were started in November 21, but that's not happening. In Sussex, it's still not brilliant. And we're not going to boast and say it's because Kate and I work in Sussex, but something is happening different in Sussex, where there is a slightly higher uptake of the drug than there is elsewhere, and we're trying to look into that, about why that's happening. Certainly in West Sussex, if we ask the areas where the pharmacies in particular are ordering it, it does appear that Kate's influence is that they are recommendations on starting the drug. In East Sussex, it's not quite so clear, but there are little sort of clusters in Bexhill and now appearing in one area where I've been doing a little bit of concentrated work in Hailsham and East Sussex. We go to the next slide, please. So you've seen two pathways previously. This is just sort of another version, and it's just a way of sort of trying to explain the the process that I would work through if I had somebody who might be eligible for Inclisiran. So I've got somebody who's got cardiovascular disease, they're having their annual review, they're already on a high intensity statin, although they may be on a low intensity statin as well, but that's sort of the first expectation. They've been tried on a high intensity statin. And if their non-HDL cholesterol is below 2.5, you don't need to do anything else. So as far as this is concerned, just to keep things simple, they'll just continue on their annual reviews. But if their HDL is 2.5 or higher, then the first thing you do is do what you've been doing already, which is you're going to review, are they optimized on their statin? Have you added ezetimibe? Now, that may not need you to be physically prescribing new drugs. You might go do a trawl through their previous history, whoever's doing the review, whether it's a nurse, a pharmacist, paramedic practitioner or GP, and say, look, we've had this conversation, they've declined a statin or an additional dose of statin or ezetimibe, we've done all that. And so what you're then going to do is you're going to want to know what their LDL is. And at that point, with the LDL result, you've got three choices. So where it is below 2.6, Inclisiran, as Kate's already said, is not an option. But there are the potential for some other drugs, in particular bempedoic acid for their LDL. Icosapent ethyl is a bit complicated, but that's basically somebody with raised triglycerides, but their LDL is less than 2.6, and it's probably too complicated to go into that yet. It has made it a bit more difficult to have so many new drugs arriving in 1 year, but obviously good for the patients in the long run. But basically, the right-hand side is if their LDL cholesterol is 3.5 or higher, as Kay said, that sort of splits into two groups. If they've got one vascular bed condition and it's over 3.5, if it's over 4, sorry, then they may be considered for PCSK9. If they are over 3.5 or equal to or over 3.5, and they've got disease in 2 vascular beds, or they've got cardiovascular disease and FH, then they may well be considered for PCSK9 inhibitors. The middle group is the one that we're talking about today, which is so the 2.6 to 3. Or under 3.5, then you'd consider adding in Inclisiran as a new option, and say that would be in primary care. So next slide, please. Okay, so the ordering. So some of the discussions and the problems have been about how you order it. So there's one wholesaler for Inclisiran, and that's AAH, and a lot of practices I know have already got contracts with AAH, and as has been explained before, it's £45 per pre-filled syringe, and you order it by whichever way you'd normally order, but that may well be just by phoning up AAH and ordering it. The best way to give it is that the practice orders it, and then you claim back as you do for your other personally administered drugs via the FP34D, and it's about a month later you'll get your money, and you'll get £55. So you get a small additional amount of money for the fact that you've that you're using this drug. It's meant to sort of support really long term with the administration fee, the cost of the nurse's administration. You can use FP10, but obviously then it's the pharmacy ordering it, which does seem to be the majority of the way it has been ordered to date in our area. And with that, then the patient will come in with the injection. The problem with that is that in the unlikely event somebody with CVD is still paying a prescription charge, because normally you'd expect if they're under 60, they're on enough drugs that they get a prepaid certificate, or they're over 60. But if they are, in that case, the problem is they end up paying the fee, and in addition you don't get the £10 fee for the administration, so you are you're losing out on that small amount of money. If you're setting up an account, the important thing is when you set it up, you need to state that this is a SOLUS, SOLUS account, and that basically means you avoid any additional charge for ordering, because if you just go to this company and it isn't a Solus drug, and you order something, you can pay, and I think it's around about £150 per order, which obviously completely negates any benefit there is to the practice financially from doing this. In fact, you're going to make a loss. Next slide, please. So the sort of issues that have come up. So first of all, which patients are eligible? Now, there's two different ways of doing this as of today. So the first one is the way that's already sort of built into practice computer systems. So if practices are using Ardens now as your search tool, then there is a way of searching. I've written it down because I keep forgetting how to do it. So if you go into your Ardens searches and you go into conditions, you then search for cardiovascular and then alerts, you will then find the Inclisiran search. You basically run it. I ran it in a practice of 12,500 patients a couple of months ago, and I suddenly thought, oh, should I have done this in the middle of a busy surgery? In fact, it didn't have any effect on the running of the computer systems, and it took 5 minutes to run. Out of 12,500 patients, there were 39 that it said were eligible. Now, one of the problems with the search using that search is that it is only people who've ever been prescribed or you've got evidence they've been prescribed statins on the computer. So, for instance, if somebody's recently moved into your practice and you search and they did have a statin a year ago, but they've moved to you and they're not taking it now, you'll miss those people. So if somebody's had a severe adverse reaction or just doesn't want to take the statin anymore, but they have, you're going to miss out on those people. So that is a potential issue with this. The other way of doing it now, the CVD Prevent, the latest update, which is data up to January, is out today. And when you get a chance to look at that, you will actually find there's an additional search now, which is people with cardiovascular disease who've got non-HDL cholesterol of 2.5 or higher. So that should give you a much better idea, and we'll be able to sort of advise you on that. And there will be an additional tool called CVD Action, I think it's called, which will actually give you the working data, which is patient identifiable, so you can go through the list. So there will be an easier way of searching for that, the top of the pathway bit, imminently. What is involved? So one of the things about this, so informed discussion. So the hardest part of this is the people that you've got who may be eligible for the drug. You're going to have a discussion with them. I said for practice I went through recently, it's 39 people, and the idea is, because this was going to be a 3-year project, now obviously coming down close to 2, you're still talking about something in the region of, for an average practice of 9,500, you're probably going to have 30 patients. So it's going to be 15 appointments a year, which is going to be with a suitably trained person to have that discussion about lipids. Now, that isn't always going to be a GP. So the practice I'm working with recently, it's one of the pharmacists is having those discussions, and it hasn't caused any significant problem with their other workload. The workload implications, we've talked about this in other groups, and Kate and I have talked about it. So after the informed discussion, the actual number of appointments is not particularly high. So the nurse is going to give an injection day 0, and then they have second dose at 3 months. And then after that, it's going to be one every 6 months. So compared to, for instance, people having to self-inject with PCSK9 inhibitors, much less. And it might be an opportunity to start looking at the other areas that maybe you could be becoming more sort of efficient and effective. One of the things is looking at B12 injections, and someone can have a conversation about that sort of elsewhere when I speak to practice and things about how many people may not actually need to be on B12 injections, but could be taking it orally, because of the sort of there isn't a huge amount of evidence that a lot of the people who have B12 deficiency need to have it by injection, and also making sure that people haven't persuaded nurses start asking for the injections every 6 or 9 weeks. And so you may be other areas that you could be cutting down appointments that you could then appropriately move to being used for this process. Once you've actually got through however many people agree to uptake the drug, obviously then the numbers you're going to get new ones coming in are going to be very small. So the informed discussions won't be very high. It's going to be just the ongoing injections for the people who are established on the drug. Kate mentioned the local commission service. So in Sussex, in addition to the £10 you get, you can also claim on the LCS. So if you have some form of LCS for minor procedures and this drug isn't on it, it's worthwhile speaking to whoever's in charge of those services to actually lobby to actually get this added, because it should be given if there are other injections, for instance, for prostate disease, etc. They're on there. There's no reason this shouldn't be as well. If you haven't got an LCS for that, again, it's worthwhile, if we've got any PCN leads or higher in the organisation that can start lobbying again to try and get one for these procedures, because I think it's entirely reasonable to look at that to see whether it's appropriate use of your funds locally. One of the big things and the reasons that the people said they're not happy is the concerns about lack of outcome evidence. We've talked a lot about the fact that this is really about anything that lowers your LDL cholesterol seems to be associated with a reduction in cardiovascular events, and the CTT collaboration, which has been going since about 1994, I think. They've done a lot of work looking at this sort of meta-analysis of all of the trials of lipid-lowering therapy, and NICE have adopted that as a surrogate marker of appropriate to use the drug, as they did, as Kate mentioned, with PCSK9 inhibitors. And remember that years and years ago, we were using rosuvastatin. I know it's an expensive drug, but people who couldn't tolerate other statins were put on rosuvastatin, when the only evidence we had was on ultrasound measurement of the intimal thickness in the carotid arteries, and that was considered acceptable as an outcome. And with ezetimibe, we didn't have any outcome evidence initially, which is now obviously something that comes to light with the Improve It study. So now we are happy that there is outcome evidence, and I feel confident we're going to find the same with this drug, although I admit that we haven't got that yet. The other reason as a GP I'm happy not to worry about that is the fact I use other drugs that haven't really got a lot of outcome evidence. I've been prescribing SSRI antidepressants for depression for years and years. And again, as you're probably aware, there's been quite a lot of questions as to whether or not there is true outcome evidence for those, although obviously there is reported evidence patients feel better with those drugs. Black triangle, I think, was another thing that was raised by the RCGP and the BMA about, GPs using black triangle drugs, and normally there's secondary care. I think that might be the case for quite junior GPs, but those of us who've been around for 20 or 30 years remember that huge numbers of drugs were coming in that were licensed that had black triangles, and we were just aware that if we'd send a yellow card in if somebody had any sort of adverse event on those drugs. And I went through the latest data. So the MRHA refer you to the EMA for the list of drugs that got black triangles. And some of them are slightly surprised. I mean, some of them wasn't surprised. That's things like Paxlovid that we use for treating symptomatic COVID-19. That wasn't really a surprise. But I didn't realise that according to the EMA list, some of the inhalers we use for COPD, such as Inclisiran, have still got black triangles on. I must admit, I didn't realise that was the case. Other drugs like Ozempic, semaglutide as a GLP-1 inhibitor for diabetes, and rivaroxaban has still got a black triangle on it. So GPs are prescribing other drugs that got black triangles. So again, I don't think that should necessarily be a serious impairment to the use of the drug. I've been trying to get worldwide data to try and work out how many orders have been worldwide, and Novartis can't give me that. There is a significant increase in the last few months of the orders here. So there's it looks as if in the region of 2,100 people have been given the drug to date in the UK since November last year. So the numbers are increasing, along with the couple of thousand as well from a couple of their landmark pivotal trials. Safety data, as Kate said, is there's very low side effects and very low interactions because of the way the drug works. It doesn't really interact with drugs that you're given orally otherwise for other conditions. And the main side effect, it appears to be about 3% of people who are given the drug will get a local skin reaction for the first dose, and that goes up to about 7% for the second dose. But it's still very small numbers, and of those, most seem to be mild. Something in the region about 1% of people are getting a moderate skin reaction. It's a good idea to give it into the belly, so subcutaneously into the belly is probably the best way that it's given. There was also concerns raised by RCGP about the green formulary status when it may not have been discussed more widely. I mean, that's a national thing now. So basically all of the primary care formularies have got it on as green, as I understand. There's a few secondary care ones, particularly some that don't use statins or any other lipid-lowering therapy at all, that haven't got it on green. But basically, it's a national agreement, and I think people feel happy that the formulary status now for this drug. I think that's really. I don't know if I've got any more slides. I think that's probably the end of it. Is it? Yeah. So I think it's really just an opportunity for people to sort of raise issues. I mean, I'm happy to speak to individual groups of GPs at PCNs or at their practices, etc. But anybody who's on the line who's got concerns or comments, then this is an opportunity to speak to Kate and I.
Sorry, I can't access the chat from my phone, but I just wanted to ask, if you're on Inclisiran, do you continue your high dose of atorvastatin or rosuvastatin as well, or do you stop it?
Yeah, you continue it all because you're trying to get as low as possible. So this is an addition to all the drugs.
Okay, thank you.
Yeah, and again, as a GP, the only thing is, if somebody is genuinely, absolutely suffering with their, I mean, I had somebody who gets these sort of suicide and murder-related nightmares from their 20 milligrams of rosuvastatin, who I've now started on Inclisiran, and I'm probably going to let him go down to 10 once his cholesterol, just because he is there, because he's had 2 cardiovascular events before. He knows he has to be treated, and he's really trying to bear with it, but we'll see what happens with his side effects once he's established on Inclisiran. But yeah, the main in most cases, if they're tolerating the drug and they haven't had any problems, it's not like a case of when people started statins, they would start eating fish and chips again. They should be doing everything they can to get their cholesterol as low as possible. And it was interesting. So even some other, not Kate, other lipid specialists were saying, like the in vitro worry about lowering your LDL too much, because this is lowering it in your blood. So it is getting into the cells where it's needed to do what LDL is needed for. So it's only that we're just not measuring it in the blood. It's not that it's disappeared from your body completely. Would you say the same, Kate? I mean, it's still it's there to do whatever it's supposed to.
Completely filled with cholesterol. Yeah, it's just out of the blood vessels. We don't need it in the blood vessels. It's everywhere else, so it's fine. Yeah.
And have you had patients who can't tolerate any statins, so they have just been on Inclisiran and it has lowered cholesterol?
We have a few people who are very intolerant to things, but generally you find the ones who have intolerances to statins, ezetimibe, PCSK9 inhibitors, and bempedoic acid tend to have the same, whatever it is, like nightmares to whatever drug, and you'll find they won't be taking antihypertensives as well. So there's a little group who can't apparently take medications. Not that I don't think they'd often class effects, but because generally, actually, this one seems to have gone down better than any other previous one, and I think it's just injection, they forget about it. So actually, fingers crossed.
Oh, thanks very much. Thank you.
Some questions. Did Mohammed have his hand up first?
Hello, Richard. Hello, Kate. This is Mo. I'm the principal pharmacist from Louis PCN. Richard, probably you remember me when you were collecting the initial information about the Inclisiran. I separate some of the information. So I've got one patient here. This particularly quite interesting because the side effects, we are kind of still waiting that the not enough documented side effects so far. While we are learning about Inclisiran, we appreciate that. It's documented only the injection site side effects or relatively mild. I've got the patient who actually has got the pain and swollen thumb. And that is drug induced, no doubt, because it never happened. But then obviously when we use the Inclisiran, then patient experienced this. It did not settle. However, the result or impact of this drug is great. We literally saw the immediate benefit. Patient is also keen to continue. But when I was trying to log in to yellow card, there is no option. I'm not sure that whether we are aware of that. This Inclisiran is not included in the yellow card online scheme. My personal experience is literally like that. Obviously, we can do the hard copy, but with current modern world, we hardly use the hard copy and send, fill the form and then send it to MHR. It is very unlikely. So I don't know whether Richard, Kate, or Jen, whether you can look into that, that whether Inclisiran, it's a fairly new drug, but it's not still included. It's black triangle drug, but it's not actually included in the yellow card online system. So it's hard to really document the side effects, because these, the more we document the side effects or our experience, that will really help us to learn for the future patients.
And hopefully, I think by adding these drugs and doing that, that may mean that the registers get updated as well to give you more options. But generally, again, whether that a sore thumb is related, because I mean, thumbs are very common sight for arthritis, isn't it? But you're right. I mean, the risk of significant hemiplegia, heart failure, and death is, if they're happy to put up with a sore thumb, definitely pursue. And I noticed a comment flash out about what the safety of a very low LDL is, and actually we have got safety data from these new drugs, but they also discovered the PCSK9 inhibitors for people having 0 LDL for the entirety of their life with no consequences. So that's what we're mimicking, people who are existing with no PCSK9 inhibitor. So from lifelong safety of rendering someone with no PCSK9 and a 0 LDL, we have these families that exist like that, and it is safe.
I'd agree with what Kay said about the so I wouldn't say you can definitely say it's drug induced, because events occur, coincidences occur, like the rainbow appearing over a funeral, and things like all sorts of things that they can be purely coincidental. So the only way you can tell with the drug is that you give something and you cause a problem, you take the drug away and the problem goes away, you reintroduce the drug and the same problem occurs. So as the drug is only in the body for 14 days, hopefully the sore thumb should dissipate over 3 months. And if it is back to the way it was at 3 months, then you're going to give the injection again. If you were worried it was still sore, then you have still got that 3-month window to give the drug again. But if they stop it and they miss the the whole length of time, then you have to start it all over again once you're sure the thumb has returned to normal. And if they then get a second sore thumb, then okay, then I think you potentially have got cause and effect. The MHRA thing, I'll find out about that. I mean, are you saying that you can't? Is it a drop down box? You can't find it in a search thing?
Yeah.
Okay, so yeah, so we'll and have you tried it under its trade name as well as?
Wait, all forms are actually tried.
Yeah,
it's a brand name as well as the generic.
Yeah. Well,
we
at the HSN can contact the MHRA and just make sure, because obviously that's the sort of thing we don't want things slipping up on somebody starting to use it and then feeling they can't report and then deciding to stop using the drug because the safety mechanisms don't work. So we'll check that with the MHRA.
Thank you. We'll definitely check that out, and I think that's one that we should add to our FAQ document as well. So thanks for raising that. I think we've got a couple more questions. I'm conscious of time, but Nagar and Thomas have their hands up, and then we've got a few comments in the chat as well that I'd like us to come to. But Nagar, do you want to?
Yes, sure. First of all, thanks to Kate and Richard for the wonderful presentation. I was a bit late, but I recently had a patient who was eligible for Inclisiran. I asked the GP to start him on Inclisiran. That's what I usually do, and I get all the GP colleague support. But for this one, actually, I get a rebound letter to say that unfortunately our integrated care board decided that this isn't a primary care setting to prescribe or to administer or to give the Inclisiran to the patient. It has to be given by yourself, or if you want to refer the patient to a local lipid clinic or any other practice that does the Inclisiran administration and all the prescription supports. My question is that can they at all do that? I mean, not to give the green light to the GPs. I mean, is that something that integrated care boards could do, or how to overcome this if we face more of these rebounds from GPs?
I'll have a go at answering it. I think so. Is this in Surrey? Yeah. So I think in Surrey, I don't think that they're sort of blocking it. I think it's more about the fact that they're yet to have the discussion about it which I think is November. I think Jen might, I think it's in the next month or two. So the thing is, because it's a primary care drug, it is green on your formulary, so you can definitely use it. No, you're not going to, you know, self-combust in flames for using the drug because they haven't discussed it yet. The ICB, I understand there are concerns, and because they're being raised by secondary care, I know the ICB may want to have that discussion. But if you feel reassured by what we can say, what NICE have said, the evidence that there don't seem to be any big problems, it is likely to end up having the same outcome data, then you can certainly go ahead, and nothing will go wrong as far as you doing that, or that you're more at risk from doing it. You know, if it happens out in primary care, it's primary care pathway. So I reassure the GP that's raising the query, but it's not being blocked because it's on their formulary. It's green on their formulary. So they can go ahead and do it, but it may be, the big problem is, for me, the reason why I've gone ahead with it, and why I always, you know, so a friend of mine said a wipe out's better than a wimp out. It's better to actually, you know, if this has got enough evidence to say go for this, we should be doing it. My worry is that if a patient came to me and said, I want to have this drug, I can't tolerate statins, then they have an MI, or it's recorded someone, they die. You know, how on earth am I ever going to explain that when I say, oh, well, it hadn't yet been discussed at the area prescribing team, even though it was on, you know, I couldn't live with myself for that. If the patient, so we should, if a patient is requesting it, or has a discussion with somebody in secondary care in a lipid clinic or in cardiology, and they say, yeah, I'd like to try that. Then I think we have a duty to offer it because it's NICE approved and it's green on formulary, etc. But I think what you could still follow that up by saying it is still being discussed locally, and you know, but I think it's the denying it is the problem I've got, and what would happen if it occurred. And if this is happening nationally, where we haven't given 100,000 doses, we've given 2,000 doses, there are going to be cardiovascular events which might not have occurred if we got to the 100,000. I mean, that's, you know, it's just the way I've always done things. I don't run away from a problem, I tend to run to it.
Thank you, Richard. Can we just come on to Thomas, who's been patiently waiting? We've only got a minute now.
So it's a really quick practical question. I'm a stroke physician. I work in secondary care. When we do a lipid profile, we get a non-HDL. We don't get an LDL routinely. Should I be asking our lab to provide us with specifically an LDL? Because we have to specifically ask for it, and it might be sensible just to do it across the board. If we're using that as a target, then
I think so. So it's only a calculation, so it won't cost any more. It's literally putting the maths into the system. And actually across Sussex, we've changed to a different equation as well. So we're now using the Samson or the NAHR equation instead of Friedewald, because it gives you LDLs with higher triglycerides. So we're reporting LDLs now up on all lipid profiles using this calculation for triglycerides up to 20 to make sure that everyone has the data they need. So yes.
Yeah, and from a GP point of view, that I know nothing about the way the trust works, but sometimes there's been things going on between secondary care and primary care. So if there's a risk that what it might mean is a GP has to then order a blood test to then get the calculated LDL, then you could have a discussion with the lab saying, just to try and save primary care, can we just do this and get it written into the calculation so you get it, and you can just tell them the figures and they can then get on with the initiation.
Sorry, what was the name of the calculation you said?
So Samson, SAMSON, NIHR. It's one of the papers. They've done a new one with it's linear with higher triglycerides.
Thank you. I'm conscious of time. We've reached 2 o'clock, but thank you everyone for attending. We will look into your questions that are on the chat that we haven't responded to and endeavour to respond to those. We will also include in the FAQ document the next version of what we can include there, particularly around that yellow card information that we're going to find out. So thanks ever so much. Please do complete our evaluation feedback survey. We've put the link and the QR code. But we look forward to seeing you. We'll share the recording and the slides with you after the meeting, and please do keep in touch. Thank you so much.
Thanks all for attending. Cheers.
Thanks, Richard. Thanks, Kate.